Welcome to this audiobook entitled Gastrointestinal and Central Nervous System Infections. Regarding demographics, the patient's name is James Worthington. His age is 42 years. His gender is male. His height is 6 feet. His weight is 180 pounds. His race is white. He is allergic to azithromycin. He developed skin rash after taking it. Regarding his chief complaint, J.W. is a 42-year-old man who presents to the accident and emergency department with a 3 to 4 day history of diarrhea and intermittent abdominal pain and cramping. Regarding his history of present illness, J.W. and his family have been vacationing for the past week out of state in the region. His diarrhea had its onset 3 days ago and has worsened. Although he reports 4 to 6 bowel movements daily during that time, he suffers from urgency and reports the feeling he has to sit on the toilet all day. Stools have been watery until this morning, when he passed a mucus, blood-tinged stool. He has taken 2 tablets of Imodium for each of the past 2 days, which slowed the diarrhea and allowed him to attend work. His illness has been associated with fatigue, occasional chills, and intermittent lower left abdominal pain and cramping. He reports no change in his appetite or weight and no night sweats since the onset of his illness. He presents to the accident and emergency department concerned about the bloody stool. Just before his vacation, he finished a 10-day course of cefuroxymaxtal that he received for a painful sore throat with laryngitis and cough productive of a greenish sputum. J.W. believes the diarrhea is related to the antibiotic use, despite his use of probiotics. His review of systems is otherwise non-contributory. Regarding his past medical history, he has no history of diverticulitis or constipation. He had an appendectomy 15 years ago, without complications. Regarding his social history, he is married with a 10-year-old son, healthy wife and son without current illness. He denies tobacco or drug use. He takes an estimate of 3 alcoholic drinks per month. Regarding his family history, he has healthy parents in their 70s. His mother had a colonic polyp removed a few years ago. There is no history of colon cancer or inflammatory bowel disease in the family. On physical examination, he is generally an alert, oriented white male who is comfortable in no apparent distress. He appears slightly thin. Regarding his vital signs, he is afebrile with a body temperature of 97.8 degrees Fahrenheit, a blood pressure of 131 systolic 72 diastolic, a heart rate of 79 beats per minute, and a respiratory rate of 16 breaths per minute. He weighs 180 pounds. His height is 6 feet. Regarding head, eyes, ears, nose, throat, abbreviated as HEENT, and pupils equally round and reactive to light and accommodation, abbreviated as PERRLA, they are unremarkable. On neck examination it is supple with normal range of motion. His chest is clear to auscultation. Regarding his cardiovascular system, he has regular rhythm. His abdomen is flat, soft, with present bowel sounds diminished, tenderness only to very deep palpation in left lower quadrant. There is no guarding or rebound. There are no masses or peritoneal signs. No costovertebral angle tenderness. On rectal examination, he has a small hemorrhoid that is not swollen, not tender, and without bright red blood present. No stool on examination is done. No tenderness is noted. His laboratory and diagnostic test results are as follows. White blood cell count of 9,700 cells per millimeter cubed with 75% polymorphonuclear neutrophils, 13% lymphocytes, 11% monocytes, 1% basophils. His hemoglobin is 15.5 grams per deciliter. He has a hematocrit of 45.6% and a platelet count of 158,000 cells per millimeter cubed. His sodium levels are 144 milliequivalents per liter, potassium levels are 4.0 milliequivalents per liter. He has a chloride of 103 milliequivalents per liter, bicarbonate content of 26 milliequivalents per liter, a serum creatinine of 0.8 mg per deciliter. His blood urea nitrogen is 10 mg per deciliter. His blood glucose is 98 mg per deciliter. His calcium levels are 9.2 mg per deciliter. His pulse oximetry is 98% on room air. Regarding his stool analysis, there is positive occult blood, with moderate white blood cells. His stool culture results are negative for Salmonella, Shigella, Campylobacter, Escherichia coli 0157, Yersinia, Aeromonas, and Plesiomonas. There is no significant number of Candida. It is positive for Clostridioides difficile C, difficile toxin A, and or B. A diagnosis of Clostridioides difficile infection abbreviated as CDI is made. Develop a pharmacologic plan for the treatment of the Clostridioides difficile. Clostridioides difficile is a gram-positive, spore-forming anaerobic bacillus. The treatment of a Clostridioides difficile infection would include antibiotics such as oral or IV metronidazole, oral vancomycin, or oral fidaxomicin. Because this is JW's first episode of Clostridioides difficile and he is hemodynamically stable, oral metronidazole 500 mg orally 3 times daily for 10 to 14 days would be an appropriate plan. Metronidazole is the recommended drug of choice for mild to moderate infections. Oral vancomycin is warranted for severe infections, and oral vancomycin and IV metronidazole can be used in combination for severe, complicated infections. Fidaxomicin was approved for treatment of Clostridioides difficile infections in mid-2011, but current U.S. guidelines lack inclusion of the drug. It was shown to be non-inferior to vancomycin for initial cure of a Clostridioides difficile infection in 2 phase 3 clinical trials. However, institutions generally reserve it for patients who experience multiple recurrent infections or fail metronidazole and/or vancomycin therapy. It is important to note that JW should discontinue taking the antiperistaltic agent Imodium because it may obscure symptoms or precipitate complications such as toxic megacolon. My second question to you is, which one of the following statements is true regarding Clostridioides difficile enterocolitis testing and diagnosis? Is it A. Clostridioides difficile enterocolitis is typically diagnosed in clinical settings by isolation of the organism from the stool? Or B. Isolation of the Clostridioides difficile organism is rare in neonates or infants? Or C. False negative testing results for Clostridioides difficile are common? Or D. The majority of patients in whom the Clostridioides difficile organism could be isolated will remain asymptomatic for diarrhea? Or is it E. Laboratory testing for Clostridioides difficile is recommended in all ICU patients because outbreaks commonly occur in this setting? Answer D is correct. Although Clostridioides difficile is not part of the bowel normal flora, it can be isolated in virtually all populations including healthy persons. D. As such, testing of asymptomatic patients and non-diarrheal stools is not recommended. It commonly colonizes neonates and infants with an estimated carriage rate of 30% to 70%. B. Pathogenic strains cause enterocolitis by secretion of cytotoxins A or B, and the diagnosis is based on isolation of the toxin rather than the organism in most clinical settings. A. Strains that do not produce toxins are non-pathogenic for colitis. Although false positive testing results C are a concern with present testing methodology, a negative testing result can be trusted. Because not all strains of the bacteria are pathogenic for disease and over 50% of patients in whom the organism can be isolated are asymptomatic for diarrhea or evidence of colitis, they can be defined as carriers versus being infected. Name at least 3 risk factors for developing a Clostridioides difficile infection. Antimicrobial exposure is a modifiable risk factor for Clostridioides difficile infections. Almost all antibiotics have been associated with Clostridioides difficile infections. Fluoroquinolones antimicrobials have emerged in the past decade as an important risk factor for Clostridioides difficile infection, having been associated with NAP1-027 strain that causes severe enterocolitis. Cancer chemotherapy has immunosuppressant and antimicrobial effects, as does the treatment for HIV disease, and both are well-accepted risk factors for the disease. Advanced age has been long known to be an important risk factor for Clostridioides difficile infection. Duration of hospitalization is also a risk factor. Proton pump inhibitor therapy has been found in several studies to be associated with an increased risk of Clostridioides difficile infection, and the FDA recently added warnings to this class of acid-suppressing medications. However, a link between Clostridioides difficile infection and the H2 blockers has not been established to date. Other risk factors include gastrointestinal surgery or manipulation of the gastrointestinal tract. My 4th question to you is, which of the following statements is true regarding metronidazole Flagyl treatment of Clostridioides difficile enterocolitis? Is it A. The drug is effective only if given by the oral route of administration? Or B. Relapse rate following a course of metronidazole is less than 2%? Or C. The drug is an appropriate first choice in patients of all conditions and ages with Clostridioides difficile enterocolitis? Or D. The failure rate for metronidazole treatment of Clostridioides difficile enterocolitis appears to be increasing? Or is it E. A 3 to 5 day course of metronidazole therapy may be used in patients presenting with mild Clostridioides difficile enterocolitis? Answer D is correct. Current treatment guidelines recommend metronidazole for the initial treatment of mild to moderate disease. Metronidazole can be used in the treatment of Clostridioides difficile enterocolitis by either the oral or IV route. The relapse rate following a course of metronidazole is estimated to be between 10% to 20%. B. And evidence suggests failure rates to metronidazole have been increasing. D. Metronidazole is not recommended for use in all patient populations. C. The drug is not recommended for patients who are pregnant. In these situations, oral vancomycin is preferred. Treatment duration of therapy of 10 to 14 days is recommended in all Clostridioides difficile patients treated with metronidazole regardless of disease severity. There are insufficient data to support a duration of therapy shorter than 10 days. My 5th question to you is, a medical resident asks you when vancomycin should be used as an appropriate alternative to metronidazole for Clostridioides difficile enterocolitis. Vancomycin should be considered for therapy in all except which one of the following patient types? Is it A. The patient is intolerant to metronidazole? Or B. The patient has failed to respond to an adequate course of metronidazole? Or C. The patient has gastrointestinal tract complications and must be treated with IV drug therapy? Or D. The patient has severe, life-threatening Clostridioides difficile enterocolitis? Or is it E. The patient is suffering a second recurrence of Clostridioides difficile enterocolitis? Answer C is correct. Although oral vancomycin is considered equally effective as metronidazole for treatment of Clostridioides difficile enterocolitis (C), it is regarded as second-line therapy for most initial disease episodes because of concern for the development of vancomycin-resistant enterococci colonization, as well as its increased cost. Unlike metronidazole, vancomycin should not be used by the IV route for treatment of Clostridioides difficile enterocolitis because adequate drug concentrations are not achieved in the intestinal lumen. Vancomycin is recommended alone or with metronidazole when the patient has severe life-threatening enterocolitis and with recurrences (DE), based on data that the duration of diarrhea may be shortened. The use of oral vancomycin is appropriate in patients who are intolerant to metronidazole. Although the initial Clostridioides difficile infection episode response rates for metronidazole are typically greater than 90%, and the drug may be utilized for the first disease recurrence, vancomycin is recommended in patients who have their second disease recurrence (B). My sixth question to you is, which of the following statements is true regarding options for the treatment of Clostridioides difficile enterocolitis? Is it A. Treatment with recommended pharmacotherapeutic agents is always required when Clostridioides difficile enterocolitis is diagnosed? B. Fidaxomicin is a newer treatment option that is superior in efficacy to vancomycin for treatment of an initial episode of Clostridioides difficile enterocolitis. Or C. Fidaxomicin has been proven to be a cost-effective treatment for all patients with recurrent Clostridioides difficile enterocolitis. Or D. Probiotics have been proven to help prevent Clostridioides difficile enterocolitis when added to antimicrobial therapy. Or is it E. Combination therapy with oral vancomycin plus IV metronidazole is recommended for initial treatment of severe, complicated Clostridioides difficile enterocolitis? Answer E is correct. The initial action that should be taken in a patient with suspected C. difficile enterocolitis is to discontinue the offending antimicrobial agent, and this action alone will result in improvement in approximately 30% of patients. A. Fidaxomicin is a newer treatment option that has been shown to be equally effective but not superior to vancomycin therapy for treatment of initial episodes of Clostridioides difficile enterocolitis. B. Due to a cost greater than that for either vancomycin or metronidazole, it will not be a cost-effective alternative for most patients with Clostridioides difficile enterocolitis. C. Probiotics have been used with antimicrobial therapy to prevent Clostridioides difficile enterocolitis development, but evidence has been conflicting, and they are presently not recommended in guidelines for this purpose. D. Combination therapy with vancomycin plus metronidazole may be used in disease recurrences and is recommended for initial treatment of severe, complicated Clostridioides difficile enterocolitis. E. Regarding the demographics, the patient's name is Trevor Knight with an age of 9 years. The gender is male. His height is 4 feet 6 inches. His weight is 64 pounds. His race is white. He has no known drug or food allergies. Regarding his chief complaint, TK is a 9-year-old child brought to the accident and emergency department by his mother with a 3-day history of diarrhea with severe abdominal cramping and pain, fever, and malaise. Regarding his history of present illness, TK is an avid young fisherman who returned earlier in the week from a backpacking and fishing trip with his father in Yellowstone National Park. They hiked through primitive areas without sanitation and camped in sites commonly used by other hikers. He states he started to feel poorly 5 days ago, which was the day after the trip concluded. His parents noted his illness 3 days ago when he developed a fever and watery diarrhea with cramping, but he continued to eat and drink in his usual amount. His mother encouraged additional fluid intake for his diarrhea and gave him acetaminophen for his fevers, which were sporadic. He was not given any anti-diarrheal medication. His mother believes his diarrhea seemed to worsen over the next 24 to 48 hours, but she says it has lessened over the past 24 hours. She notes continued malaise in the child and states that he now looks sicker than when the diarrhea started. The child has continued to complain of abdominal pain throughout the illness. Today he noticed his stools contained blood and mucus, which was confirmed by his parents, who decided to bring him to the clinic. His mother also notes increasing lethargy in the child in the past 24 hours. His review of systems is otherwise non-contributory. His past medical history is non-contributory. There are no serious diseases other than a few typical childhood otitis media and upper respiratory infections. No serious injury is recorded or reported. Regarding his social history, he lives with his parents and 3 sisters, ages 2, 4, and 6. Regarding his family history, his father is aged 39 years with controlled hyperlipidemia. His mother is 36 years old and healthy. His 2 sisters are healthy. His grandfather died of a heart attack at age 64. Other grandparents are healthy. There is no known history of cancer or diabetes in the family. Regarding his immunization history, he is up to date. Regarding physical examination, generally he is a juvenile white male who is oriented, alert, and cooperative to exam but clearly lethargic. He appears to be in moderate distress and complains of abdominal pain. Color is somewhat pale, and he appears to be mildly to moderately dehydrated. Regarding his vital signs, he has a body temperature of 102.3 degrees Fahrenheit taken orally. His respiratory rate is 20 breaths per minute, a blood pressure of 124 systolic 78 diastolic, a heart rate of 72 beats per minute. He weighs 64 pounds. Regarding the head, eyes, ears, nose, throat, abbreviated as HEENT, his oral mucous membranes are dry. Pupils equally round and reactive to light and accommodation, abbreviated as PERRLA, is otherwise unremarkable. His neck is supple without masses. On chest examination, his lungs are clear to auscultation. The cardiovascular exam reveals a normal rate and rhythm. Abdominal exam reveals bowel sound increased in all quadrants, diffuse tenderness, no masses appreciated, no rebound tenderness, no evidence for peritonitis, patient does guard on palpation but rigidity not present. On neurological examination, reflexes equal and symmetrical. Motor strength is normal. Regarding the rectum, only external exam is done. There are normal findings with no fissures. Regarding his skin, there is slight loss of color consistent with some dehydration. Regarding the laboratory and diagnostic tests, the results are as follows. Sodium level of 135 milliequivalents per liter. Potassium levels of 3.8 milliequivalents per liter. Chloride levels of 98 milliequivalents per liter. Bicarbonate content of 22 milliequivalents per liter. His blood glucose level is 120 mg per deciliter. He has a blood urea nitrogen of 18 mg per deciliter. His serum creatinine is 0.5 mg per deciliter. His aspartate aminotransferase is 25 international units per liter. His alanine transaminase is 22 international units per liter. His INR is 1.0. His white blood cell count is 10,300 cells per millimeter cubed with 85% polymorphonuclear neutrophils, 8% lymphocytes, 5% monocytes, 2% eosinophils. His hemoglobin is 14.3 grams per deciliter. His hematocrit is 40.9%. His platelet count is 305,000 cells per millimeter cubed. Regarding his stool analysis, it is watery, red-brown in color with mucus in appearance, positive for occult blood and white blood cells. His stool culture is positive for Shigella sonnei, negative for Salmonella, Campylobacter, and Escherichia coli serotype 0157, ova and parasites, and Clostridioides difficile toxin. A diagnosis of Shigella gastroenteritis is made. According to his medication record, he takes acetaminophen 2 teaspoons orally every 4 to 6 hours pro Renata. My first question to you is all except which one of the following characteristics help to distinguish bacterial from viral gastroenteritis in TK. A. Recovery of fecal leukocytes from the stool is common in bacterial gastroenteritis but rare in viral gastroenteritis. Or B. Bloody diarrhea is common in bacterial GE but rare in viral gastroenteritis. Or C. Travel-related gastroenteritis can be caused by either bacterial or viral pathogens. Or D. Elements of dehydration were present in TK, and those rarely occur with viral gastroenteritis. Or is it E. Temperature elevations, fevers, are typically more elevated in bacterial compared to viral gastroenteritis? Answer D is correct. Viral gastroenteritis due to common causes, including rotaviruses and noroviruses, is typically associated with watery diarrhea and vomiting. Usually, the watery diarrhea is non-inflammatory, and no fecal leukocytes are found in the stool. Although fevers sometimes occur with viral gastroenteritis, they are mild in nature. Although some types of bacterial gastroenteritis, such as that caused by Vibrio cholerae, may present with a secretory diarrhea profile common to viral etiologies, the presence of fecal leukocytes, bloody diarrhea B, and fever E is suggestive of a bacterial cause and commonly used to make empiric treatment decisions. Both bacterial and viral causes of gastroenteritis occur in association with ingestion of contaminated food or water, as may occur during travel. C. For example, norovirus outbreaks have occurred on cruise ships and in school systems. Dehydration is common D, and a primary treatment issue with either bacterial or viral gastroenteritis. My second question to you is, what is the most common pathogen in acute gastroenteritis in children less than 10 years of age? Rotavirus is the most common cause of severe diarrhea in children in the world and remains the most common cause for hospitalization from viral gastroenteritis in the United States. Infection most commonly occurs in children 6 to 24 months of age, and outbreaks are common. Treatment is supportive. Vaccination for rotavirus is available in the United States and is administered at 2, 4, and 6 months of age. And the third question reads, what was the most important risk factor for the development of shigellosis in TK? The most important risk factor for TK was his travel in an area with poor sanitation. Although tainted food is the most common source in the United States, contaminated water is a typical source. Shigellosis typically affects children younger than TK, although he is within the age spectrum for the infection. Although summer is the time when most shigellosis is encountered, the infection is uncommon in the absence of a risk created by poor sanitation or an epidemic setting. Shigella outbreaks are also associated with crowded living conditions, such as child care centers, nursing homes, and group housing scenarios. Specifically, children under the age of 5 years who are in child care settings are at increased risk of Shigella infections. The fourth question: which antimicrobial agent is preferred in current pediatric guidelines as the treatment of choice of shigellosis? There are no recent practice guidelines for gastroenteritis from the Infectious Diseases Society of America (IDSA), but guidelines exist from the American Academy of Pediatrics. Azithromycin is the current drug of choice in children with shigellosis, although reduced organism sensitivity to that agent has been recently reported. Increased resistance to ampicillin has also been seen, and amoxicillin is less effective against Shigella due to quick absorption from the gastrointestinal tract. Similarly, Shigella resistance to TMP/SMX has also increased. Although quinolones like ciprofloxacin are recommended for use in adult patients, they are usually avoided in children. However, ciprofloxacin is an alternate treatment in children. Ceftriaxone is also an alternative to azithromycin use and preferred over a fluoroquinolone in the pediatric population. Treatment is generally for a duration of 5 days. Although mild infections may not require antibiotics, patients with severe disease, dysentery, or immunocompromising conditions should receive treatment with IV antibiotics. The fifth question reads: all except which one of the following statements are true regarding Shigella gastroenteritis in the entire population? Is it A. Shigellosis is commonly a self-limited disease that does not require antimicrobial therapy? Or B. Shigella sonnei is the most common cause of shigellosis in the United States? Or C. Shigellosis in the United States most commonly occurs in adult patients? Or D. Shigellosis is diagnosed by the isolation of the organism in a stool culture? Or is it E. Shigella has no natural reservoir in nature and is passed from person to person? Answer C is correct. Shigellosis is usually a self-limiting disease, with recovery occurring within a week without antimicrobial therapy. However, it is important to note that viral shedding may occur for 1 to 4 weeks after the onset of illness. The most common cause of shigellosis in the United States is Shigella sonnei B, which has replaced Shigella flexneri as the predominant isolate. Shigella dysenteriae is a common cause in undeveloped countries. Shigella has no reservoir in nature E, and is spread person to person in a fecal-oral transmission pattern. The incidence of shigellosis in young children less than 5 years of age is approximately 10 times that seen in adults. C. Shigellosis is diagnosed by the isolation of the organism in a stool culture. D. And the sixth question reads: what type of medication is not recommended for patients like TK who suffer from bloody diarrhea and dehydration in association with shigellosis? Antidiarrheal agents such as difenoxylate or loperamide slow intestinal motility. They are not recommended in bacterial gastroenteritis characterized by bloody diarrhea. There is concern that use of the agent may slow gastrointestinal clearance of the infecting organism and worsen the episode. Regarding the demographics of a patient whose name is Tony Depp. He is aged 22 and of male gender. His height is 6 feet 2 inches. His weight is 210 pounds. He belongs to the white race. He is allergic to sulfur drugs to which he develops rashes. Regarding his chief complaint in his own words, "I have the worst headache of my life." Regarding his history of present illness, TD is a 22-year-old college senior who was brought to the Accident and Emergency Department by his girlfriend on October 20 due to decreased energy, general malaise, and an excruciating headache since last night. His symptoms were of sudden onset and have persisted about 6 hours. The patient attended a party the night of the onset of symptoms. He denies illicit drug use but did consume 5 cans of beer prior to the development of symptoms. On admission to the Accident and Emergency Department, the patient continues to complain about headache, sensitivity to light, and neck stiffness. The patient has vomited once since presenting to the Accident and Emergency Department and is continually nauseated. Regarding the review of systems, examination reveals an ill-appearing young male who is only able to respond to questions intermittently with yes or no answers but denies any focal pain. The patient appears somnolent but is arousable. Regarding his past medical history, TD has a past medical history of seasonal allergies as well as intermittent insomnia. Regarding his social history, and specifically his travel history, during summer, he backpacked across Western Europe, that is France, Germany, Spain, and Italy. Regarding tobacco use, he is a social smoker. He smokes approximately 1 pack every 2 weeks. He began smoking at the age of 16. Regarding alcohol use, he takes approximately 12 drinks per week, mainly on weekends. Recreational drug use is denied by the patient and girlfriend. Regarding caffeine use, he takes 2 cups of coffee per day. The caffeine use is doubled during exams. He lives in an apartment with 2 other male roommates. Regarding his family history, his father is a 50-year-old male who is alive and well with hypothyroidism. His mother is a 51-year-old female who is alive and well with no known medical problems. Regarding his vaccination history, he receives the influenza vaccine annually. Regarding the childhood series, he is up to date. On physical examination, he is generally pale, well-nourished, lethargic male in no apparent distress. Regarding his vital signs, on accident and emergency department admission, his blood pressure was 110 systolic 68 diastolic. His heart rate was 120 beats per minute, his respiratory rate was 22 breaths per minute, his body temperature was 102 degrees Fahrenheit, his height is 6 feet 2 inches, he weighs 210 pounds. Regarding head, eyes, ears, nose, throat, abbreviated as HEENT, there is no papilledema on examination. His pupils equally round and reactive to light. This is a patient with photophobia. His chest is clear to auscultation. Regarding the cardiovascular system, his heart has a regular rate and rhythm, abbreviated as RRR, with normal S1/ANS S2 and no audible murmur. His neurological examination shows he is intermittently alert, oriented to self. The patient is unable to state where he is or what day it is. Nuchal rigidity is present. He has a positive Brudzinski's sign, and a positive Koenig's sign. Regarding his extremities, they are notable for several petechial skin lesions on arms. On his skin, petechii are present as noted below. Laboratory and diagnostic tests results are as follows. Sodium levels are 140 milliequivalents per liter. Potassium levels are 4 milliequivalents per liter. Chloride levels are 106 milliequivalents per liter. The bicarbonate content is 28 milliequivalents per liter. His blood urea nitrogen is 30 mg per deciliter. His serum creatinine is 1.3 mg per deciliter and the blood glucose levels are 106 mg per deciliter. His hemoglobin is 16.2 grams per deciliter and the hematocrit is 49%. His platelets count is 281,000 cells per millimeter cubed. His white blood cell count is 20,600 cells per millimeter cubed with 75% polymorphonuclear neutrophils, 18% bands, 3% lymphocytes, and 4% monocytes. His blood toxicology and alcohol screen is negative. His head CT is normal. His chest X-ray is also normal. Lumbar puncture is done. His cerebrospinal fluid has a white blood cell of 2,700 cells per millimeter cubed, 88% segs, 6% lymphocytes, and 6% monocytes. 10 red blood cells, with a glucose content of 7 mg per deciliter, a protein content of 610 mg per deciliter. The cerebrospinal fluid gram stain contains gram-negative diplococci. A diagnosis of meningitis is made. According to his medication record, his home medications include fluticasone 50 micrograms, 1 spray per nostril daily, and zolpidem 10 mg, 1 tablet pro Renata for insomnia. My first question to you reads, name 2 organisms that are the most likely pathogens in our 22-year-old immunocompetent patient with suspected community-acquired meningitis. Streptococcus pneumoniae and Neisseria meningitidis are the most common causes of traumatic, community-acquired meningitis, with the latter pathogen more likely due to the cerebrospinal fluid Gram stain. Listeria monocytogenes is an infrequent cause overall, but its frequency is increased in infants younger than 1 month, adults older than 50 years, ethanol abusers, immunocompromised, and patients with comorbid conditions, i.e., diabetes, liver disease, chronic renal disease. Haemophilus influenza type B meningitis was historically the most common cause of meningitis in neonates, but not in adults, and it is no longer of high prevalence in this country due to the widespread use of conjugate vaccines that can now be given as early as 2 months of age. Group B streptococci are common causes of meningitis in the neonate. Staphylococcus aureus, Acinetobacter baumannii, Pseudomonas aeruginosa, and Bacteroides fragilis are not frequently encountered in community-acquired meningitis but may be encountered in the nosocomial setting, particularly in the patient with CNS trauma, due to injury or surgery. My second question to you reads, which anti-infectives would provide optimal, yet the most narrow-spectrum, empiric coverage for meningitis prior to microbiology laboratory findings in this patient? Ceftriaxone provides effective coverage for Streptococcus pneumoniae and Neisseria meningitidis. Vancomycin is added for coverage of penicillin-resistant isolates of Streptococcus pneumoniae. Gentamicin, azithromycin, and cefazolin, as well as all other first-generation cephalosporins, poorly penetrate the CNS and should be avoided for treatment of meningitis, although gentamicin may be administered intrathecally when infection is caused by a resistant gram-negative aerobe. Meropenem is an appropriate empiric treatment option for meningitis as well. Daptomycin has not been sufficiently studied clinically at this time, and the pharmacokinetics regarding CNS penetration have not been determined. Metronidazole exhibits a high level of CNS penetration, but activity is limited to anaerobes. As a result, this agent is frequently used when the presence of anaerobic organisms is suspected or confirmed. However, anaerobes are not a frequent cause of community-acquired meningitis. Fluconazole is used exclusively for treatment of fungal infections, which are not common in an immunocompetent individual. Ceftazidime is not required in this patient as Pseudomonas aeruginosa coverage is not necessary. If a patient presenting similar to TD had a severe penicillin allergy, i.e., anaphylaxis, the patient should receive chloramphenicol for appropriate coverage against Streptococcus pneumoniae and Neisseria meningitidis. If the penicillin allergy is considered non-severe, i.e., rash, then it may be necessary to challenge the patient with a cephalosporin because the patient has a relatively safer toxicity profile. In vitro data regarding fluoroquinolone treatment, especially using newer agents, for Neisseria meningitidis are positive. Clinical data are sparse but emerging. And my third question to you reads, after 3 days of therapy, the pathogen is determined to be Neisseria meningitidis. Which statement most accurately summarizes the utility of corticosteroids in this patient? Is it A. Dexamethasone should be initiated in this patient because the culture confirmed Neisseria meningitidis? Or B. Dexamethasone should be initiated in this patient to decrease inflammation associated with concomitant enterovirus infection? Or C. Dexamethasone should have been initiated early in this patient, but delay in therapy and uncertain efficacy of dexamethasone in Neisseria meningitidis precludes its current utility at this point in the clinical course? Or D. Because the culture confirmed Neisseria meningitidis, dexamethasone should not be initiated in this patient as it will decrease the penetration of vancomycin, and vancomycin will be unable to treat the Neisseria meningitidis? Or is it E. Dexamethasone should not be initiated in this patient due to the patient's leukocytosis? This is a black box warning and an absolute contraindication. I will give you 10 seconds to choose the correct answer to this question from the listed options. Answer C is correct. Dexamethasone therapy has been shown to be beneficial in the empiric treatment of certain adult patients' meningitis. The available data suggest that adjunctive dexamethasone should be given prior or concomitant to receiving the first dose of antimicrobial therapy. Patients who have already received antimicrobial therapy are unlikely to benefit from the anti-inflammatory properties of corticosteroids. TD, however, has not received any corticosteroids at day 3. Therefore, answers A and B cannot be correct. In addition, some experts believe that benefit is only realized in patients with Streptococcus pneumoniae meningitis. Although dexamethasone has the theoretical ability to decrease vancomycin concentrations in the CSF, clinical data support its use. However, vancomycin is not useful in the treatment of Neisseria meningitidis. Therefore, answer D cannot be selected. Finally, the absolute stated in answer E, or the presence of a black box warning, does not exist for dexamethasone and leukocytosis. Therefore, the answer is C. Additional information is available for the reader from the IDSA Practice Guidelines for the Management of Bacterial Meningitis, available at www.idsociety.org. And my fourth question to you reads, what are the prophylaxis regimen options for household contacts of a patient diagnosed with community-acquired meningitis caused by Neisseria meningitidis? Does his girlfriend warrant prophylaxis? The Advisory Committee on Immunization Practices has published guidelines for the proper prophylaxis of Neisseria meningitidis meningitis. These include rifampin 600 mg orally every 12 hours for 4 doses, ciprofloxacin 500 mg orally at once, or ceftriaxone 250 mg IM at once. This information can be accessed at http://www.cdc.gov/mmw/preview/mmw/r5407a1.htm. Chemoprophylaxis is recommended for close contacts of patients diagnosed with Neisseria meningitidis meningitis, which includes household contacts, daycare center members, and anyone directly exposed to the patient's oral secretions. Thus, his girlfriend should be provided prophylaxis. Healthcare workers need not receive prophylaxis unless direct exposure to respiratory secretions exists. And my fifth question to you reads, TD has been in close contact with his sister, who is currently 8 months pregnant, and her physician wants to initiate chemoprophylaxis. Which chemoprophylaxis regimen should she receive? Rifampin is an FDA pregnancy category C, and it has been associated with hemorrhagic disease of the newborn. Studies involving pregnant women are generally supportive that rifampin is not a teratogen. However, its use should be avoided if other alternative agents are feasible. Ciprofloxacin is an FDA pregnancy class C drug, due to animal mutagenicity, and alternates should be used when available. Therefore, ceftriaxone 250 mg IM stat dose is recommended, and an FDA pregnancy category Class B drug should be used. And my sixth question to you is, which populations does the Advisory Committee on Immunization Practices, abbreviated as ACIP, currently recommend receiving routine administration of the Neisseria meningitidis vaccine? Routine administration of the meningococcal conjugate vaccine is recommended by the CDC for pre-adolescents and young adults, ages 11 to 12, and individuals at increased risk for infection, including microbiologists who are routinely exposed to meningococcal bacteria, U.S. military recruits, asplenic individuals, people traveling to countries with meningococcus outbreaks, persons who have terminal complement component deficiencies or human immunodeficiency virus, and those who might have been exposed to meningitis during an outbreak. Infants and children 2 months to 11 years of age and adults, including the elderly, should receive the vaccine if they meet criteria for a high-risk condition. All children should receive a booster dose at 16 years of age. The demographics of a patient named Greg Jeffries are as follows. This patient's age is 50 years. The patient belongs to the male gender. His height is 6 feet 4 inches and his weight is 233 pounds. His race is white. He is allergic to penicillin. He experienced anaphylaxis the last time he took it. Regarding the chief complaint, GJ is a 50-year-old white male who is admitted to the hospital for treatment of asymptomatic neurosyphilis. GJ is without complaints and reports no manifestations of infection. Presence of infection was identified when a routine screening test, conducted in conjunction with application for a marriage license, was positive for syphilis rapid plasma Reagan antibody. Follow-up specific treponemal tests of serum and cerebrospinal fluid confirmed the presence of infection. Regarding his history of present illness, GJ reports no complaints at present. He notes that he received treatment with unknown antibiotics 7 years ago for an STD that he acquired during a period of sexual indiscretion following his divorce. At that time, he presented with dysuria and a purulent urethral discharge and was informed that he had gonorrhea. He noted at that time that the infection was most likely acquired from one of several one-night encounters with women he had met in a bar. He was unable to identify the index source, so follow-up and treatment of the reference case did not occur. Following treatment, he reports rapid resolution of symptoms and no subsequent sequela. He denies observing the occurrence of any manifestations or symptoms suggestive of syphilis following this course of treatment. A review of systems is normal. Regarding his past medical history, GJ has a history of hypertension that is currently controlled and a history of STD exposure as noted above. He also reports a history of a severe allergic reaction to penicillin. He notes that 23 years ago, he received a prescription for penicillin for treatment of a sore throat. Immediately after taking the first dose, he noted shortness of breath accompanied by swelling of his face, neck, and tongue. He was rushed to the accident and emergency department, where he received a shot of adrenaline, and was observed until symptoms abated. He was informed at that time that he should avoid penicillin or all penicillin-like antibiotics in the future. The remainder of his history is unremarkable and is non-contributory. Regarding his social history, GJ has been divorced from his first wife for 8 years and has been involved in a monogamous relationship with his current partner, to whom he is engaged, for the last 2 years. He reports that he used condoms with all his sexual contacts following diagnosis and treatment of the STD 7 years ago up to his current partner. He reports that he and his fiancée quit using condoms about 3 months into their relationship. Regarding tobacco use, he confirms chewing 2 cans of tobacco per week. Regarding alcohol use, he takes 3 to 4 beers or glasses of wine per week. Regarding caffeine use, he takes 3 to 4 cups of decaffeinated coffee per day. Regarding his family history, his father died in a motor vehicle accident at age 58. His mother is alive at age 72. He has 2 brothers aged 58 and 52 and 1 sister aged 44. He has 3 children aged 26, 24, and 19. On physical examination, he is a generally well-nourished white male and no abnormality is detected. His vital signs include a blood pressure of 134 systolic 82 diastolic, a heart rate of 72 beats per minute, a respiratory rate of 20 breaths per minute, a body temperature of 37.5 degrees Celsius. His height is 6 feet 4 inches, and he weighs 106 kilograms. Regarding head, eyes, ears, nose, throat, abbreviated as HEENT, he is normal. He has no adenopathy palpable. Regarding his lungs, there are clear breath sounds. Regarding his cardiovascular system, there is a regular rate and rhythm, abbreviated as RRR, with normal S1 S2 and no audible murmur. His skin has no erythema or petechiae. His genitourinary system is normal. His neurologic exam shows he is alert and oriented. He has normal reflexes elicited and normal gait observed. Laboratory and diagnostic tests are as follows. Sodium levels of 144 milliequivalents per liter. Potassium levels of 4.5 milliequivalents per liter. Chloride levels of 103 milliequivalents per liter. Bicarbonate content of 22 milliequivalents per liter. His blood urea nitrogen is 25 mg per deciliter. His serum creatinine is 1.2 mg per deciliter. His blood glucose level is 110 mg per deciliter. His hemoglobin is 12.4 grams per deciliter and he has a hematocrit of 37%. His platelet count is 385,000 cells per millimeter cubed. His white blood cell count is 5,600 cells per millimeter cubed with 75% polymorphonuclear neutrophils, 20% lymphocytes, 4% monocytes, and 1% eosinophils. Regarding his serum, rapid plasma Reagan is 1 to 256, fluorescent treponema antibody absorption is reactive. His CSF shows VDRL of 1 to 32. A diagnosis of neurosyphilis is made. According to his medication records, he takes amlodipine 5 mg orally once daily. So my first question to you is, what is the most appropriate treatment, drug and regimen, for the following? A. Neurosyphilis. B. Primary syphilis. And C. Primary syphilis in a penicillin-allergic patient. A. According to the CDC Sexually Transmitted Diseases Treatment Guidelines, 2015, aqueous crystalline penicillin G 18 to 24 million units per day, administered as 3 to 4 million units IV every 4 hours or continuous infusion, for 10 to 14 days remains the drug of choice for treatment of neurosyphilis. A penicillin-allergic patient will require penicillin desensitization. B. Benzathine penicillin G 2.4 million units IM single dose, is the most appropriate treatment for primary syphilis per CDC Sexually Transmitted Diseases Treatment Guidelines, 2015. Infants and children should receive benzathine penicillin G 50,000 units per kilogram IM, up to the adult dose of 2.4 million units in a single dose. Combinations of benzathine penicillin, procaine penicillin, and oral penicillin preparations are not considered appropriate for the treatment of syphilis as the drug formulation may not penetrate infection sites well. C. According to the CDC Sexually Transmitted Diseases Treatment Guidelines, 2015, doxycycline 100 mg orally twice daily or tetracycline 500 mg orally 4 times daily for 14 days or azithromycin 2 grams orally as a single dose are alternative treatments for primary syphilis in a patient with a penicillin allergy. Concerns of azithromycin resistance and treatment failures have occurred in several geographical areas of the United States, thus, it should be used with caution and if penicillin or doxycycline is not practical. Ceftriaxone 1 to 2 grams daily IM or IV for 10 to 14 days is effective but the optimal dose and duration is questioned. My second question to you is what are characteristic findings of primary, secondary, and tertiary neurosyphilis? The defining lesion of primary syphilis is the chancre, which forms at the site of inoculation, most commonly the external genitalia. A rash that usually begins on the trunk and proximal extremities and involves the palms of the hands and soles of the feet is a characteristic presentation of secondary syphilis. Other signs of a secondary syphilis infection include mucocutaneous lesions and lymphadenopathy. Cardiovascular or gummatous lesions are characteristic of tertiary syphilis. Meningitis, stroke, cranial nerve dysfunction, or altered mental status are characteristics of neurosyphilis. My third question to you reads, GJ is initiated on treatment and calls the nurse later that afternoon with complaints of fever, headache, and sore muscles. What is the best recommendation for GJ? The Jarisch-Herxheimer reaction occurs shortly after administration of an effective antibiotic, most frequently penicillin in patients with spirochetal infections. The reaction is thought to be due to pyrogen release after spirochetal lysis. The infection is most frequently associated with initial treatment of syphilis but can occur in patients with other spirochetal infections, including leptospirosis, relapsing fever, and Lyme disease, or bacterial infections, including anthrax, tularemia, brucellosis, and rat bite fever. The reaction is generally self-limiting, characterized by fever, headache, and myalgias, and is usually treated with NSAID therapy. My fourth question to you reads, what is the drug of choice for the treatment of syphilis in a pregnant patient with a penicillin allergy? According to the CDC Sexually Transmitted Diseases Treatment Guidelines, 2015, pregnant patients with syphilis should receive parenteral penicillin G for the treatment of syphilis at any stage. If the patient has a penicillin allergy, she should be desensitized. And my fifth question to you reads, in monitoring a patient for the treatment of syphilis, what lab change would indicate efficacy of treatment? Titers of non-treponemal tests, e.g., rapid plasma Reagan, are monitored for efficacy for the treatment of syphilis. A four-fold reduction in rapid plasma Reagan is a marker indicating efficacy of treatment. If a patient's titers do not decline four-fold within 6 to 12 months after treatment for primary or secondary syphilis, treatment failure should be considered with additional clinical and serological evaluation. Fluorescent treponemal antibody absorption is a treponemal test that is qualitative only and used to confirm the diagnosis of syphilis. My sixth question to you reads, what combination of labs and clinical disease meets the definition of latent syphilis? Is it A. positive rapid plasma Reagan, negative fluorescent treponemal antibody absorption, and the absence of clinical disease? Or B. positive rapid plasma Reagan, positive fluorescent treponemal antibody absorption, and the presence of clinical disease? Or C. positive rapid plasma Reagan, positive fluorescent treponemal antibody absorption, and the absence of clinical disease? Or D. negative rapid plasma Reagan, positive fluorescent treponemal antibody absorption, and the presence of clinical disease? Or is it E. positive rapid plasma Reagan, negative fluorescent treponemal antibody absorption, and the presence of clinical disease? I will give you 10 seconds to choose the correct answer to this question from the listed options. Answer C is correct. By definition, latent syphilis is seroreactive without clinical evidence of disease. The rapid plasma Reagan is a non-treponemal test and thus a screen. The fluorescent treponemal antibody absorption is a treponemal test and thus confirmatory for the diagnosis of syphilis. Thank you.